Our names are Susanna Stanford and Sarah Seddon. We met through speaking to medical students about our experiences as patients, sharing what could be learned from our care. But we've also been learning from the people we speak to. We have developed an appreciation of how adverse events impact clinicians and other healthcare professionals. There is a lot of stigma around adverse events, error and failure, but we recognise we are all human and none of us are perfect. So we wanted to share a message about managing adverse events in healthcare. We want to help you face the inevitability of something going wrong and to help you see what you can do to be prepared. Manage an adverse event well and you will not have failed your patient. What matters is working together to achieve the most positive outcome for your patient as well as yourselves.
We know that people go into medicine with good motivation. In fact, the best doctors are possibly the people who will feel adverse events most acutely. Medical students are high achievers. Having specialised in the sciences, they're accustomed to knowing the right answers, and they're also used to knowing what they need to do to excel. Then they go into medicine, which often isn't even about choosing the best option, but the least worst option.
There is tremendous uncertainty. Every decision is a balance of risks and benefits, often calculated on incomplete data. Circumstances can be against you. You could be on a ward in the middle of the night and be faced with a patient whose symptoms bear no resemblance to what you've learned, while another 5 patients need your attention too. Trainees can and will experience fear for their patients and for themselves.
We appreciate why it's so difficult and why sometimes things go wrong. Some doctors turn to unhealthy lifestyles, some leave medicine, and some take their lives. We don't want that to be the case. We care about the people who care.
But before we talk about things going wrong, a thought about working safely. Early on in your careers, you have to assimilate technical skills and knowledge so fast that it can be quite hard to appreciate and make time for non-technical skills. But no matter how technically brilliant a clinician is, they cannot guarantee they will deliver safe care unless they develop their non-technical skills. There are many cognitive and behavioural factors which we can both understand and anticipate, which have an impact in a clinical settings. Factors which can either promote or compromise patient safety. We encourage you to learn about human factors because then you'll recognise them. And more to the point, you can develop strategies to support safety. No matter how experienced you become, it's important to behave in ways that reduce the probability of making mistakes. This includes encouraging your team, together with the patient, to share anything they're not sure about. When one looks at multiple patient safety investigations, one consistent theme is of patients not being listened to. Without listening, clinicians lose a vital source of information, whether from the patient themselves or their family. Hearing what is said and how contributes to clinicians' situational awareness, their ability to consider critical information in a dynamic situation. It's important to appreciate that when we talk about patient safety, we're talking about behaviours which keep you safe too.
So let's start with you, Susanna. Tell me a bit about your experiences.
So I had a spinal anaesthetic fail for a C-section. Really everything should have been fine. It was planned surgery because I had an anterior placenta previa. However, whilst the anaesthetic worked on my motor nerves, the effect was patchy on my sensory nerves. During testing, I struggled with one particular question, and unfortunately the anaesthetist repeated the same question several times. I felt under enormous pressure to give the go-ahead. There was a room full of people waiting. I was aware of the expectation that the block should be working. I was lying on my back looking up into the face of someone who was convinced the block would be working. He was the expert, the person with authority. We talk about hierarchy in medicine now, but clinicians need to be aware that the patient experiences it too. It is astonishing to me that I agreed to an operation starting when I was not sure that the block was working. But I did. And I knew how wrong that was when I felt the first incision. The operation was stopped on 3 occasions, twice for me to be given fentanyl, a potent synthetic opiate, and a third time to be given a general anaesthetic after my son was born. It was immensely traumatic, particularly because I was focused on the safe delivery of my child whilst I was experiencing indescribable pain, pain that I perceived as life-threatening. When I came round afterwards, I was just glad to be alive. But the experience was compounded when things were not handled well by the anaesthetist and the trust. Despite verbal admissions at the time, when I was discharged, my GP received only the most basic discharge information, which described a routine C-section under regional anaesthesia. It was 10 months later that I went to my GP because I was really struggling with symptoms of post-traumatic stress. And only when I told her that she learned I'd had a general. It was the most basic thing which she should have known. And that would have given her a clue that things hadn't been straightforward. She wrote to the hospital asking for an opportunity to go through my notes, and she received a letter back which stated I had been conscious and comfortable at the time of delivery. Obviously, had I been comfortable, there would have been no need for a general. The outcome was not catastrophic. I had life-saving surgery and my son was all right. But because my experience was not represented in my notes, there was no support.
So where do you think things went wrong?
There was no technical error. It came down to a failure of non-technical skills. I know now there are a number of heuristics, mental shortcuts, which can lull someone into making mistakes. The most likely in my case was confirmation bias, which is a tendency to pay attention to things which confirm what you're expecting to see. The anaesthetist will have been used to spinal blocks working, because most do, but the point of testing is looking for the ones that don't. I now tell anaesthetists that rather than expecting to confirm that the block is working, they need to work on the assumption that the block is not working until they can prove that it is. There were other issues around communication. While it was one convoluted question which derailed me, that might not have caused a problem if only the anaesthetist had really listened to my responses. The fact I was not sure should have alerted him that something was not right.
There were just some really striking similarities between our experiences. Our experience of hierarchy and finding it hard to voice concerns, but also not being listened to, both at the time and in the aftermath.
So, Sarah, let's move to your experience so people can understand what happened.
It was during my pregnancy with my 5th baby. I had 3 daughters, a 7-year-old plus 4-year-old twins. And previously I'd had a baby boy who'd been stillborn due to Patau's syndrome. Because of this, I'd been quite anxious during the pregnancy and I was having extra antenatal visits and extra scans just for reassurance, but everything had been completely fine throughout. When I was nearly 27 weeks pregnant, I realised that I hadn't felt my baby move for at least 24 hours and I became worried, so I called my community midwife for advice. I was offered an appointment later that day and she listened to the baby's heartbeat, told me that everything was fine and sent me home. She dismissed my concerns and said that it was normal for babies to suddenly stop moving at this gestation. She said that it had probably just changed its position. But she did not follow the guidelines. With completely absent fetal movements, I should have been sent immediately to hospital for a CTG, and I should have had a full antenatal check. But my trust was unquestioning. I was completely reassured, and I can just remember feeling so relieved. It was only a few days later, when I could still feel no movements, that I spoke to a different midwife who referred me immediately to the hospital. And I just remember feeling really guilty for being such a worrier and for wasting the professional's time. So I was on my own when I was scanned and when I was told that my baby had died. I had to give birth to him 2 days later, and his name was Thomas. We left hospital believing that we'd received appropriate care and that we were just really unlucky.
When did you realise maybe you should have been given different advice?
It was 4 months later at a consultant review, and I was told there was a separate investigation and report underway. It was almost a throwaway comment, and I didn't really appreciate how serious it was until the serious incident investigation report arrived in the post about 2 months later, when I was at home on my own on a Friday afternoon. In the report, my midwife had written a statement to say that I'd refused blood pressure checks and urine checks, and that I'd refused to go to hospital. She said that she had measured my bump, but that I hadn't noticed her doing it. The report implied that it was my fault my baby had died, because it incorrectly stated that I had refused to follow the advice of my midwife. But nobody at all had asked me what happened. It's unthinkable that a woman in my position would refuse care when she had been asking for help. It just left me feeling that my family and my baby were completely inconsequential, and the damage that that report did is still with me today.
There's a really great Vincent and Davis paper where they describe patients as privileged witnesses of healthcare in the sense that they are at the centre of the treatment process. It is wrong to dismiss patients' experience.
But that's exactly what happened. So then I had to go through further processes over 2.5 years, which included a repeat serious incident investigation, an investigation into how the original investigation was carried out, providing witness statements for HR investigations, then a fitness to practice investigation by the healthcare regulator with a full public hearing, followed by a second fitness to practice investigation initiated due to issues being missed the first time around. The lowest point was at my midwife's fitness to practice hearing, where I was cross-examined by a criminal barrister for 2 hours on all aspects relating to Thomas's death. I felt like I was on trial for something, and I had to defend myself, my child, and my reputation, all with no representation, and without the support of my husband, who wasn't allowed to be in the room. These extra years of agony for me and my family were completely preventable. I can accept the fact that my baby died and that humans make mistakes, but I honestly feel that the harm caused to us since Thomas's death has been much, much worse than the harm caused by his actual death. Bear in mind, I have experienced the grief of losing another child, and this time it was made so much worse. Had we been treated initially with honesty, respect and compassion, it could have been so different. But the loss of trust stays with you.
I agree. It makes it difficult to look beyond what's happened to understand why. I had to work very hard to hold on to a fundamental belief that no one had intended to do me harm. But that was immensely challenging, because when I saw a letter which stated I had been conscious and comfortable, I felt sick at the injustice of being presented an account of my experience, which was not true. Of course, clinical notes leave out human experience, but something can be wrong in the notes. And as other people become involved, people who were not there at the time, they give more weight or pay more attention to the notes rather than the patient experience. This means the patient can be presented with something that they see as an intentional lie, whilst also feeling that it is implied that they are lying themselves.
Exactly. And at that point, it becomes them and us, instead of a restorative process which could rebuild trust and enable open communication, support and learning.
Something every harmed patient I've ever spoken to has said is that they just want people to learn from whatever went wrong. Patients want a just culture, but they get pushed into the adversarial process. I knew nobody learns when they feel on the defence, so I decided I had to find a different way to achieve learning. But I still felt I was taking clinicians on, that it was me against them. It was only once I started speaking at conferences that I realised how willing people were to listen and to learn. It emphasised to me how devastating it must be for clinicians when something goes wrong, and how difficult it can be to tell the truth if they feel they're going to be blamed. People need psychological safety.
I agree. And at the moment, patients are often cut off with no communication after the event, but they need care to get through the aftermath, just as clinicians need care. The adverse event should be the starting point of a new care pathway. When it comes to clinicians, the second victim effect is well known, but in terms of consequences for patients, it's often only the physical ones which are considered. All clinicians have got a duty of care to address the psychological well-being of patients after harm.
Especially because there are so many people for whom life is already tough enough, whose circumstances may be compounding factors which affect their health. It should not be the case that anyone's experience of healthcare might add to those factors, but badly handled adverse events affect people's willingness to access healthcare in the future, both for themselves and their families. Both trauma and loss of trust have profound consequences.
We care as much about positive outcomes for clinicians as we do about positive outcomes for patients.
The uncomfortable truth is that you may contribute to something going wrong, but it will have been within a system which allowed it to happen.
It can be daunting to consider something that you hope will never happen, but mental rehearsal is important in developing your skills to handle it. We spoke to Professor Suzette Woodward, who started her career as a paediatric intensive care nurse before becoming an expert in patient safety. We asked her to describe a clinician's typical response to an adverse event.
So when things go wrong in healthcare, there are three things that we do to ourselves. Firstly, personalisation. We believe that it's absolutely all down to our fault. It's a my thing, it's an I thing. If I hadn't done this, this wouldn't have happened. Secondly, it becomes pervasive. It's going to ruin every single aspect of my life, whether that be my personal life, my future career, my relationship with my colleagues. It's going to ruin absolutely everything, because they're just going to feel that I'm just useless because it's got back to that personalisation issue. And thirdly, it feels like a sense of permanence. I'm going to feel this bad forever. So these three things, the three Ps, personalisation, pervasiveness, and permanence, is pretty much what everyone feels when something goes wrong. And what you need to do is make sure that you've got somebody who will hold you gently, listen to your side of the story, and be there for you. Because they will help you realise it wasn't all down to you, and it's not going to ruin every aspect of your life, and you aren't going to feel this bad forever. I know that for a fact, because when I was in paediatric intensive care, I was responsible for a drug error where a child received 10 times the dose of a drug. And I felt all of these things. And while it's never gone away, and I will never forget about it, I don't feel like it's going to ruin every bit of my life. And I haven't felt that bad forever. And I know it wasn't all down to my personal fault.
As Suzette highlights, this is a normal reaction to an abnormal situation. Most people's jobs don't involve the possibility of feeling responsible for harm to others.
It's easy to react feeling as though the worst thing has already happened and being paralysed by the fear that there's absolutely nothing you can do to make it better. But there is always something that you can do. There's so much you can do to ensure compassionate, ongoing care for that patient. You've got a responsibility to make sure your patient gets continued care. And doing so allows you to know that you're being the best clinician you can be. I honestly believe that trust in healthcare can be enhanced after an adverse event if everyone involved is looked after properly and if the serious incident investigation is done well.
So what helps? You need to have the tools ready to pull yourself away from the debilitating downward spiral of feelings of fear, shame, and powerlessness. The two keys are reflection and connection. Together, these give context and perspective to be able to respond to and to recover from adverse events. Now, when we talk about reflection, we don't mean sitting and writing it down, because reflection is more than another tick box exercise, and we don't want what's good about it to be lost by the Bauer-Garber case.
Reflection involves a commitment to continually learn how you can best help people. This is about using your intelligence to work out what made something good and what could have been better. It takes awareness and curiosity to improve, to become the kind of doctor you'll have started out wanting to be. And patients want those kind of doctors.
Reflection is a skill in its own right, and like anything, you have to practice to get good at it.
When something goes wrong, reflection can help by allowing you to objectively consider what happened. Looking at things from the outside, you can see that you were doing your best, and you can identify what factors were involved. If you do it well, you'll be able to forgive yourself.
But to recover, you're going to need connection too. Medicine is highly competitive. No one wants to be seen to have flaws or weaknesses, and it can be tough to admit mistakes. But everyone needs someone they can talk to, and someone who will listen.
You need to find people who you feel safe with, who you can ask for help and support, and you need to be honest with them. There are more people to support you than you may realise. A relative, a friend, a peer or a mentor. It might be the hospital chaplain, occupational health, or the freedom to speak up guardian.
What will ground you when something goes wrong is being able to connect with others. You will need to have someone who will listen to you with acceptance and empathy, and you will need to be that person for others. It is through connection that we have strength.
Together, reflection and connection help when it comes to responding to your patient. Manage adverse events well, and you will not have failed your patient.
Good communication is never more important than when things haven't gone well, both in ensuring the patient understands what has happened and in finding out what they need. Moreover, a genuine apology is vital, and it can be as healing for the person making it as for the person receiving it. It's all about being kind, but to yourselves too.
If you hide something, nobody can learn from it. But bring it out into the open and everyone can learn. When the worst happens, all families want is to be treated with respect and compassion, and for others not to suffer as they have. If you're not actively working towards learning, you're actively letting things go wrong. It is possible to recover, to continue to practice, and to be better and safer than before.
While our experiences obviously relate to maternity, the messages apply whatever your specialty and whatever your role in healthcare. In particular, we ask that senior managers and trust boards support staff in this. Communication, listening, kindness, respect, honesty. They're all irrevocably intertwined and best summed up for me by the experience of another mother who first time round had an experience which was similar to mine. She wrote to me after her second daughter was born, and this is what she said. I very much wanted a second baby, but once pregnant I felt truly terrified at the possibility of going through a C-section again. Having been told I had imagined my pain, that really it was only pressure, made me feel like a wimp, that I'd been weak and had failed at giving birth. I could not shake the fact that the level of pain I experienced was just that, and was not normal. So I sought the opinion of an anaesthetist. I described what had happened, fumbling for words to describe my feelings of embarrassment and the reaction and dismissal I'd had from the team. She looked directly at me and told me she completely believed me. She searched for your video online and left me to listen, and I cried as your experience resonated so strongly with me. For the last few months of my pregnancy, I was no longer anxious, simply because I was heard, I was believed, and would have experts looking out for me. My second section was incomparable to my first. I could enjoy the moment my second daughter arrived into the world. I don't suppose anaesthetists are often known by the patient to be the hero in the room, but the consultant and the doctor who administered my block were mine that day. There is always just as much that can be learned from excellent care. Reflection should not be reserved for when things go wrong. We've spoken because we care about those who care. We hope that by drawing together the patient and clinician perspectives, we've shown how honesty, kindness, and open communication is best for both, that we all need the same things, that we are united in our shared humanity, and that there is always hope.
Thank you.